Good afternoon, everyone. Thank you all so much for joining. So I suppose we'll make a start then. My name is Marina. I am the webinar coordinator for Evidence Synthesis Ireland, and we're delighted to welcome you all to our monthly webinar series. So just by way of brief introduction, for those of you who may not know much about us, ESI, which includes Cochrane Ireland, is an all-Ireland initiative funded by the Health Research Board and Research and Development Division of the Public Health Agency in Northern Ireland. Our aim is to build evidence synthesis, knowledge, awareness, and capacity on the island of Ireland. We have a number of key activities for achieving that aim, and one of them is a monthly webinar on an evidence synthesis topic. So we have two presenters today, Lynn and Karen, who are on the line, and we are absolutely delighted to have them and to learn from their expertise. I will just introduce them before I hand over. So Karen Hahn is an associate professor in qualitative methodology and metasynthesis in KU Leuven Faculty of Social Sciences, Leuven in Belgium. Presenting with her will be Lynn Hendricks, who is a global South doctoral scholar working on the HAART review, which we'll talk about today. So Lynn is affiliated to Stellenbosch University in South Africa and also to KU Leuven University. So just a little bit of background to the topic before we dive in. Transdisciplinary approaches to healthcare present opportunities for modern medicine to shift its focus to the overall health and well-being of patients. This shift opens up new ways of understanding diseases and the complex interplay between people's living or healthcare environment and the biopsychosocial dimensions of their experiences with a particular illness. In their latest review project, Lynn and Karen extended the BPS model, commonly used as a logic framework to make sense of qualitative research evidence with a new materialistic perspective. So they focused their review on HIV perinatal infected adolescents on highly active antiretroviral therapy, HAART, in low and middle income countries. However, the new logic model they derived at material and analytical lens they propose are transferable to other review projects dealing with the complex interaction of human and non-human agents in studying healthcare practices. So just before we dive in, we have turned off video to ensure there's good sound quality for all our attendees. We will have time for question and answers at the end, so we do encourage you to type your questions in below. There is a Q&A box, and we will have time for this at the end. So I think that's pretty much everything from me for now. So without further ado, I hand over to the experts, Lynn and Karen. Thank you so much, and take it away.
Thank you so much for this nice introduction. So this is Karen speaking, and we will swap amongst us over time. I coordinate a research group which is called Something, and it stands for Social, Methodological, Theoretical Innovation. So my group is Transdisciplinary, and we actively push towards the development of methods and models for positive change, mainly in society. So we test, evaluate, implement, improve, perhaps sometimes also develop new approaches and models in a variety of disciplines, both on the primary and the meta level. And of course, the meta level is the focus of this chat. So we're going to entertain you with the title, How Does Matter Come to Matter in Studying Adherence to Antiretroviral Therapy of young people perinatally infected with HIV, and we particularly focus on low to middle income countries. I brought with me today one of my core staff members, Lynn Hendricks, who is doing a PhD on this matter. Lynn, is there anything you want to add from your side that people would have to know about you? And then perhaps we'll move on to the outline.
There's a lot to know, but have to know, I'm not so sure. So I think just as some background to this, I am from a psychology background, so research psychology, counseling psychology, and later moved into epidemiology. And this PhD is a transdisciplinary PhD that is based both in public health and in social sciences. And merging those two disciplines together has culminated in this. One of the first outcomes is this project, which is very exciting and happy to share with everybody today.
Okay, So let's move to the outline then, Lynn. I'm aware of the fact that a systematic review community is a large community and it hosts people with very different methodological backgrounds. So perhaps I thought it would be good to situate our work first within that broader community and then move on to where we see potential for change in how we approach primary evidence, but also analysis in systematic reviews.
Sorry, Karen and Lynn, just to interrupt. Lynn, is it okay if you share screen? We can just see the notes on the side.
Okay.
Oh, sorry.
No,
can you see?
Perfect. Thank you so much. Sorry to interrupt. Thanks, everyone.
So in our case, we specialize in qualitative evidence synthesis, and what we've done so far is try and apply some of our newly emerging ideas to our own review projects. So we hope that this then inspires some of you to perhaps take some of these new ideas on board. In terms of situating our qualitative evidence review, you can see here systematic review in the middle, which implies mainly a standard systematic approach to retrieving, critically appraising or assessing the quality of primary research studies, and then using that evidence in terms of informing a particular review questions. And there's two major streams in there. Meta-analysis is actually a technique where we pool quantitative of numerical data together, and qualitative evidence synthesis deals with summarizing textual, perhaps for some people also visual or tactile types of data, so everything that is non-numerical. And we tend to compile mosaics out of these texts and visuals in a particular theory. Some reviewers would opt to bring numerical, textual, visual data together in a review, and that's what we perhaps can call a mixed method review then. And all the other areas on the screen, like umbrella reviews, rapid reviews, scoping reviews, they all apply these same principles, but have a slightly different focus. What we're going to focus on today is qualitative evidence synthesis, which is our main area of expertise. And you can click one further, Lynn, to bring up the table. Yes. Okay, so the term qualitative evidence synthesis is actually an umbrella term. It's like a big circus tent. It hosts different approaches. Some of them you might have heard about: meta-ethnography, critical interpretive synthesis, perhaps thematic synthesis or framework synthesis is something you are already familiar with. And each of them comes with a set of underlying assumptions, principles, if you like, about how we tend to see or engage with our world or our social reality. So on the one hand, you have guest researchers who look at evidence from a realist perspective. It's pretty much similar to how quantitative researchers would approach a topic. So I call that the window approach. We look out of a window and there's a reality out there. And when you look through that window, you see the same thing as I do. So therefore, it must be the case that that reality out there can objectively be described and studied. On the other hand, we also have a community of qualitative evidence synthesis reviewers who are idealist in nature, and they believe in the principle of multiple realities. So what I see through the window is not the same as what you do. We subscribe different meanings to what we see. And we also have an active role in creating particular realities. And that's because the window is seldom as clear and transparent as the positivists might assume. It might be blurred, and when it's blurred, then perhaps what we see is only a shadow. So we have to fill things in based on our own knowledge and perspectives. So it's like putting a lamp in a dark corner of the unknown or things that are unclear and trying to create and compile an overall picture. And the consequence of that is that that configuration might look different in your case than in mine. So it opens areas for debate. For the project on therapy adherence, we chose to position ourselves a little bit closer towards the realist end, so in the area of thematic synthesis. Yeah. So in what follows, we would like you to join us in a search for the best possible lens to approach a very complex problem of therapy adherence of these young people perinatally infected with HIV. And I'd like to pass the word to Lynn now to give a little background to our topic of interest in there.
Thank you very much, Karin. So my study is positioned in South Africa, and that's where I am conducting my PhD fieldwork. But the review that we are doing is contextualized in low to middle income countries. HIV is one of the most funded and studied diseases in the world, with both patients, medical practitioners, and the public invested in participating in the production of knowledge and around creating a narrative around HIV. The number of adolescents living with HIV is increasing in South Africa. So in most countries, HIV infection rates are going down. In other population groups, age groups, it is still going down, but in the adolescent cohort, it's going up. What we do find is that with adolescents, there is a cohort that has emerged over the last few years of adolescents growing up with HIV, they were infected vertically and may have tested positive through HIV transmission from mother. Previously, so years and years back before PrEP, most young kids would die early because of HIV, but because of treatments that we have available for mothers and for children, the cohorts are growing older and living into adolescence and well past adolescence, which presents an area of research that doesn't have a lot of information with how they engage with the world and how they engage with treatment adherence. The most recent review focusing on the adolescent continuum of care in South Africa specifically estimated that there are 860,000 HIV positive adolescents between the ages of 15 and 24, and of these, only 14% have accessed HAART. It's been projected that by 2025, the number of young people in sub-Saharan Africa is expected to increase to 436 million. This explosive growth in the adolescent cohort really calls for immediate and accelerated efforts to reduce the number of new infections, but to also increase adherence rates for young people living with HIV. So when we look at non-adherence in adolescents living with perinatally infected, who are perinatally infected, they have special consequences related to their HIV condition and treatment adherence. They may experience more treatment failure. There's an increased risk of onward horizontal transmission of HIV. They may experience high progression of the disease, high hospitalization rates, higher morbidities, and experience more drug resistance than other groups who are not, who had not acquired the disease perinatally. So this is our population of interest for the review and where we focused our question on. It was important for us to do this review because the solutions to complex health problems are deeply rooted in the social determinants. Simply targeting interventions blindly at barriers and facilitators with having a richer understanding of the complex interaction between influences will likely lead to inefficient use of resources and poor outcomes. It's important to understand how these conditions are influenced by social determinants such as the social gradient, social exclusion, work, unemployment, social support, addiction, transport, and a host of other factors so that we can address this global health inequities. Most qualitative reviews have looked comprehensively at linkage, retention, or adherence. And there's been substantial changes into art eligibility and art delivery in recent years. What you see in front of you is a theoretical model of a review that we published last year. And how that started out is that we initially wanted to do a review on barriers and facilitators to adherence for people living with HIV. When we started that review, we found so many existing reviews that actually culminated into an overview of qualitative systematic reviews. But we also identified gaps in the existing reviews and did another one with this model. And looking at this model, we see that there are factors that influence people to either adhere or not adhere. And what we have is called the tipping point. So all these factors may be the same for somebody. There is something, there is a variable that changes somebody's influence either to adhere, to engage into treatment, or to disengage. When I looked at the findings of the review, that firstly identified the grouping, so the population for our current review, which is perinatally infected adolescents, because we hardly found any information on them. But it also let me see that, you know, there isn't a lot around structural factors or any other factors that is beyond what you see here. And that got us thinking more around materialism, and that's what we're going to be talking about and what Karin will introduce shortly. So the initial review aim of the current review we're presenting is to explore experiences of treatment adherence to art for young people with perinatally acquired HIV in low to upper middle income countries, starting from a general theoretical model used in research. And the model we chose to focus our research with is the biopsychosocial model to understand health, which identifies biological factors, psychological factors, and the social context. First, we wanted to explore the lived experience, and second, we also wanted to extend the biopsychosocial model commonly used as a logic framework to make sense of the qualitative research evidence with a new materialist perspective. And now where the psychology part starts to blend in with the epi part, and we start to get this transdisciplinary approach. The aim of this presentation today is to illustrate how we use the new materialist lens to make sense of qualitative research in this qualitative systematic review. So Karin, I'm going to hand it to you.
So maybe you've asked yourself, why would you then challenge a model that has worked so well on many projects? The biopsychosocial model is well known and it has served a lot of theoretical thinking. It situates a lot of projects. So what is this new material lens specifically? So I'm going to give you a little bit of a background on why we think we should look at complex problems such as therapy adherence a little bit differently than what we're actually used to. So before Lynn embarked on her PhD project, we had a couple of conversations about the area where she lived, which is Bonteheuvel in South Africa. And I had traveled in South Africa, but had little awareness of how her neighborhood looked like, what might complicate the process of therapy adherence there. And I remember that Lynn was talking about how the clinic where we sent the youngsters to was located at the edge of two different communities. And these were actually separated by a main road, and it could only be crossed via a small bridge, which was an area that many perceived as unsafe to walk. And we also shared a lot of anecdotal evidence, imagining what it would be like to carry pills around on a daily basis, what sort of medication we took, hygienic stuff we carried around in our handbag, how that looked like, how, for example, the way it was shaped made it easier or more difficult to transport it into our handbags, and so on. And so that made us actually realize that we hadn't thought much about physical realities whatsoever of coping with HIV and ART, or about the materiality of things and how these things were strong agents in even shaping our own behavior. So rather than seeing things and environmental markers as passive elements that we as humans controlled, we felt that these things and spaces strongly controlled us in a sense. And so I invited Lynn to try and spot for such markers in the primary evidence available to the review project. And Lynn, you had identified some.
Yes. So in this slide, we're trying to show you and also lean on what Karin was speaking to, that theoretical models that we use doesn't really capture the complexity of therapy evidence. And what I have on the right-hand side is on the 7th of October, so it's very recently, there is a Facebook page for the Bontebal community. It's got over 20,000 on there. And the counselor for the community writes this: today we handed over the Bontebal CBD to the contractor to commence the start of the CBD. It's a proud day for all concerned, but more specifically, a day that people of Bontebal can celebrate. The project is driven by the people of Bontebal, and in a few short months, people will have a center they can be proud of. Consistent change has been something that Bontebal continues to experience as our environment changes our lives and future will too. And I found that very interesting because a lot of my study is based on the community and the structural factors and the elements in the community environment, how that influences health behavior and decision making. The second example is the that you see on the left-hand side. So I myself have a chronic health condition and I take a multitude of pills all the time. And the size, the shape, the taste, the feel of those pills really make a difference to how I experience my treatment adherence. I also really related to, Karin said that we spoke about that, I really related to carrying pills with me during the day and how I stored them, I kept them, also influenced my treatment adherence. So it's right thinking we then moved more and more into this review.
Yeah. So we actually came to the point where we said, what if we could indeed embrace this very idea of using spaces, things, thing power, materialities in our review project, and would that challenge the analytical strategies we use to review evidence? Would it perhaps make a difference on how we represent evidence in our review? And are there any theories that we could consider that could guide us through such process? So what we came up in the next slide is a new materialist theoretical lens. And this lens challenges two dimensions. It challenges the purely linguistic approach, our focus, if you like, our focus on text, which is in itself a meaning-making process coming out of the human mind. And so traditionally in qualitative evidence synthesis, we focus strongly on text and thoughts from humans. So in other words, text puts the human thought central to the process of inquiry. And so it's the human that acts upon the environment, it's the human that acts upon an object, not necessarily the other way around. And we sensed from our own anecdotal evidence and what we saw that it could be the other way around. So it pays a lot more attention to physical material markers and gives humans a more modest position in research. And so in essence, what it does, which is visible at the word cloud here, it not only pays attention to material, it also gives it vitality, if you like. So matter, according to new materialist, is alive. It's not passive. It has a certain agency. It has the capacity to influence humans as much as the other way around. So the word cloud here provides some insights to the terms used to describe matter. It's alive, it's lively, it's vibrant, it's dynamic, it's agentive, and thus active, but to a large extent, therefore, also partly unpredictable by the human mind. So consequently, new materialism subscribes perhaps to a realist sense of understanding, a window approach, but it does so from a very relational perspective, from the perspective of interaction between humans and other than human elements. And that could be particularly interesting when studying processes, for example, processes of adherence, as is the case in our study. So we try to sort of untease the principles of it, or the tensions we experience as a reviewer in working with that idea of vital materiality. So if new materialism is all about relations, but they are not necessarily flowing from one actor to another or from a cause to an effect, then how do we represent our insights if it's not meant to be a line with an arrow connecting concepts or variables? So that we found that challenging. So if these interactions are between humans, other than humans, non-humans, if they are unpredictable and they may flow in different directions even, then how do we set boundaries around therapy adherence? And if we combine the concept of effect we are used to with affect, how can we build storylines about effects and meaning making without putting the human mind central in there? So how does that think power work in practice? And I was lucky enough actually to sit in a committee of a architectural student. So my source of inspiration on the next slide was actually the study they conducted about the perspective of the lying patient. And I mean with lying patient, the one who is flat on his back and looking at the hospital or moving through the hospital very much from a bedside perspective. And I came to realize that the world in a hospital looks very different from the position where you are when you're permanently moved around in a bed. Compared to a position where you walk in the hospital. So I remember this scene where the patient illustrates what she sees when she's on her back through the window, which was literally nothing. And her visitors, though, had a beautiful skyline of buildings and a view to the park. So coming back to the window metaphor, I realized that this window indeed issued a certain agency over her, as was the position of her in the bed. And it would have never occurred to me to ask, for example, in an interview about these aspects of patients' experience. So I invited Lynn again to think about things with agency in her personal HIV research project. So what you see next slide is indeed some of the markers that Lynn talked about before. Is there anything you want to add, Lynn, from these pictures?
No, you can go ahead, Karin.
Okay. So what we did is we sought for a mixture between conventional systematic review practice that would be recognizable to our community and aligning ourselves with this new material perspective and logic in our review. And what Lynn is going to talk us through now is a little bit of how she built her review and how we try to breed some of that new materials logic in there.
Thanks so much, Karin. I also just want to acknowledge Professor Ken Matai, who has joined the call. So she's one of the supervisors of my PhD project. So welcome, Kathy. So in this review, my inclusion criteria was quite specific and very conventional for review methodology. I focused on adolescents living with perinatally acquired HIV between the ages of 10 and 25 years. The search was from 2006 to January 2020. I searched in 5 databases, the reference of included studies, grey literature for primary studies, and focused on qualitative studies in low to middle income countries. The screening and data extraction was done in duplicate and independently by 3 reviewers. What you see in front of you now is my Prisma flowchart. So from the initial 1,059 citations, we included 53 articles into this review. From included studies, and I put this graph up with years of publications, it's important for me to look at this graph because our existing review that we published in 2019 searched up to 2016. And as you can see, there was a large increase in number of published papers between that time. When looking at the outcomes of the included studies, and for this view, we are looking at treatment adherence, but we're also looking at the lived experience, which could include many of these outcomes as we try to make sense of the experience of treatment adherence. So the outcomes in the included papers mostly on treatment adherence, and some of them focus specifically on the lived experience of young people, and then others touched on disclosure, retention in care, linkage to treatment, and geographically, they were quite widespread, with the biggest cohort or group of papers coming from Uganda and South Africa and Kenya. So there are lots of African countries who have published in this area with this particular age group. And in our number of participants, looked at 1,939 adolescents with perinatally acquired AD. We did methodological quality assessment using the CASP. How I've presented it here is that the green indicates that the question was answered yes for all the papers. So as you can see, out of the subset of papers, they mostly yeses to these questions, except for question 6, where we couldn't really discern whether it was a yes or a no, but there were definitely no's in question 6 and question 8. Next, I want to speak about how we categorize papers. So conventionally, normally, when I do qualitative primary research, we can consider a research study in its description when we have either thick or thin. And how we categorize thick or thin was that the thick study had a conceptual grounding. It had quotes that supported the conclusion. It had thick descriptions of the data, and the thin study didn't really meet those requirements. But when we were looking at the analysis of the material components of the papers, we then also categorized the papers as material intense. So this top bar is for richness, and on the categories down here, we're looking at material intense. And here it was looking at, did the papers specifically target multisensory components? So for example, we had a paper that was included around photo voice, and then there was also a thesis included that spoke to the multisensory experience of the pills that adolescents take, and those were coded as high, so material high papers. Then we also had material low papers, which means it didn't even come out in the paper. There was no mention or there were no specific themes related to non-human objects. And then the mid paper was called not targeted but present. So the authors weren't looking for the non-human spaces, places, environments, but they do mention it in the data, in the quotes it's there, and in the discussion. So for example, talking about environment that people have to live in, speaking about the dorm rooms or hiding pills under the bed, those were considered medium papers in terms of material intense. So when I first started my analysis using the material, and I want to show you, this is the diagram I initially started with when I wrote my proposal, I think in 2018, and also wrote the review protocol. And what we have in this diagram is that is the material dimension as a separate dimension to the biopsychosocial dimension. So we understood that they were connected and that they influenced one another. We kept the material as separate. So when I translated that into how I extracted the data, I extracted it using the framework of the biopsychosocial model, and you can see I've split the social up into relationships and educational systems, and I also identified another category for the political health system layer. So this is one study, and here are the themes I extracted, and here are the material elements that I extracted from the data. So including the toilet space, they spoke about bottles of water, money, and skin rashes. What we found that this was not getting to the agency of the material, we were simply just listing objects. And it still wasn't bringing across what we were trying to find or trying to show in terms of the complexity of the relationship between the elements. So then we tried a second attempt. And in this attempt, I'm not sure if you can see it here, we basically added the political, we've added the material, but yeah, if you look at my second data extraction, so this is the same study, I have the 4 categories and I have the themes that I found in the papers. So I've got them codes. Social was relationship, religious institutions, psychology was motivation, stigma, and depression. And then I linked the material to each of these within the categories that we had. So now we were looking at the materials and matching it with the themes. And so yeah, what I started to do is linking them in pairs, and I started calling them material agents. So here you have examples where we identify the material agentic elements that interact with young persons to produce meaning in the experiences. So in the biological dimension, the theme was change the body, and the material agent was the rashes they experience, the hair loss they experience, they're feeling more attractive and physically stronger. The biological sensations like the nausea, the pills that were hard to swallow because they are weak, so they hurt their throats. On the psychological level, motivation, they felt motivated to adhere, and using condoms showed they felt this motivation and wanting to be healthy and to not spread it to their partners. There also sense of internal stigma. A lot of the young people describe the world is becoming and is starting to feel like a box, and I'm trapped in. There was a lot around suicide ideation, depression, anxiety. These are verbatim from the papers, how young people described, their thought process around their HIV status. Here are some examples of the sociological dimensions, so presentations of hope, such as the church or the mosque. And then we have the health system, the actual test where people, went to test for HIV, the road that they traveled on, so it's very far or dangerous or unsafe, the school or the clinic where they have to choose between where they take their medication. But it still wasn't getting to the inter and interactions. And it suggested linearity, categorical thinking, while real life therapy adherence practice did not seem to be linear at all. Kept going back to the tipping point and thinking about, it's not this neat linear way of thinking and how adherence happens. It challenges it within entanglement theory. So this is our third to build a new model. And the only way we got there was through unconventional ways of analyzing the data. And if you see this model, we have integrated the material within each of these and matter at the center of things. So we have the human and non-human objects in the middle influencing one another. Karin, and I'm going to hand over to you here.
Yeah, perhaps what you saw in the previous model is also more emphasis on the red dots. So instead of keeping us into the modus of thinking in categories, we moved towards a system in which we thought about events. And so the red dots in the figure actually represent these events, and events, they circle across the dimension and enter each of these domains. So it was actually an attempt to move away from strict silos of thinking towards something else. So that's what you see as a move, is from more classical conventional ways of reasoning in terms of themes within fixed categories. We moved to a way of reasoning that was clustered around these events. And we initially were happy with this outcome, but then again, once you start reporting, you are in fact thrown back to the core assumptions of your lead theory. In our case, that was new materialism. And for a theory that actually challenged the linguistic, textual, humanistic approach, it somehow felt a little bit inappropriate to just put words on a sheet about the model. So we felt that didn't do much justice to the core assumptions of that new materialist approach at all. So let's bring you back to that initial point of view we had with some of the principles. Principle one, the relationality. So we start from the principle that there's a fundamental relationality of all matters, bodies, things, social formations, if you like, and that each event or phenomenon is actually an assemblage in itself of elements in relation to each other, and these are of a non-causal nature. The second principle about dynamics, we had to look at, so to speak, fluctuating assemblages that coalesce to produce events, and it looked much more in practice like throwing a stone into a pond and seeing how these ripples actually shift from the center to the side, but are actually open. They don't stop, they keep on moving. And sometimes these ripples are interfered by the ripples of another event or stone that is thrown into the pond there. So that seemed to be a much better metaphor to describe that complexity. When we move from effect and affect, so from effectiveness and meaning-making processes as something that should be studied separately to affect, we also see that we can't work any longer with a fixed reality. So the diffractive metaphor of the stone in the pond actually helped us a lot there. Also in imagining what flatness could look like. So you have two different models on slides here. One is more linear and throws lines between concepts, and the other is more diffractive in nature. It doesn't give any weight, it doesn't give a clear direction either, but it suggests a movement with certain boundaries that are open for interpretation. So our challenge was to think about how can we then represent a complex phenomenon such as therapy adherence from this diffractive logic as a metaphor. And that's what Lynn has tried to do with her insights, which we would like to share.
So now I'd like to share with you the findings of our review. And we have a mother who's given birth to a child, and the child is growing up and taking medication, and she's not really sure why I have to take these pills. The other issues the child may deal with at this time, such as loss of the parents, and the mother at the time is confused about disclosing the child's HIV status to him or her, and keeps going back between, should I tell him or should I wait for to go to the clinic? Maybe the sister can tell her, or the nurse can tell her what her status is, why she's feeling sick, or going to the clinic that is so full. There are always people. There's really no privacy. People are going to see me in the line. Mom, why do we keep coming here? I don't understand what is wrong with me. And my friend's mother is here. They're going to see me. They're going to think I have the AIDS. Mom, I'm here and I'm taking the test. You said that you would tell me why. And this nurse comes and she's got this big file, and in the she tells me that I have HIV. The nurses sometimes are supportive and sometimes they are not. And sometimes I feel like I'm going to die. My parents died, my father died, someone else I knew died. Am I going to die? I feel so trapped and depressed. I feel like I don't have to live for. My friends are going to laugh at me. People are going to make fun of me. But also, I want to live. I want to have my own family. I know that treatments are available. I know that there are better ways of caring for myself. My family is supportive. Also, I want to have a career. I don't want to give up on my dreams. But when I travel to the clinic, when I walk to the clinic or I take public transport, I'm so afraid that people will see me. And I always have to remember, I can't tell anyone. I feel like I'm in a box and I'm so lonely. I'm so afraid that I have to hide. My body is reacting to the medicine. My hair's falling out. I started getting scars on my face. The treatment isn't working, and still I can't tell anybody. Even the church and the mosque that I go to, they tell me that I just have to do what my mother says or tell me to do what my husband says. And people are there all the time. The medication, the pills are so big. It's so noisy in this container. They say I need food, but I don't have any. I don't know what to do. I hide them in my trouser pants. I place them in my pocket. I actually put them in the bed of my dorm. Sometimes I go to the toilet and I take them. I don't want to hide. I'm not sure how to tell my partner, but we really need to use condoms. I have so many decisions. Life is filled with fear, stigma, and even going to the clinic back and forth, the waiting times, I have to choose between school and work. And I always have to negotiate these secrets. So what we end up with is adherence as a multi-sensorial experience of spaces and places. And this is what I have as the findings of the review now. Karin, so I can hand over to you.
Yeah, sure. Let me just quickly wrap up because we're running out of time. So some of the lessons learned, Lynn, on the next slide is that the use of such a theory led us into discovering other, more layers of a phenomenon such as therapy adherence by focusing on the material. But at the same time, it reshaped our way of approaching things analytically and representing findings very much. So if you click on click a little bit more, Lynn, then you see a move in how we change from linear thinking to categories with permeable boundaries to something of a mosaic, and then later on something that is more moving and in flux and in permanent living status, so in permanent development of becoming. So I think that to the essence captures what we've learned so far, moving from a static figure to something that can be extended over time and letting loose of the idea that things need to be connected through lines and arrows to actually start making sense to an end user. So we came to understand that therapy adherence is perhaps less about human preference and motives and needs and wishes, but more about how bodies, the virus, things, social structures actually assemble and how this relates to other phenomena. And this is really an invitation perhaps to put the human less central, to allow you to see different things emerge. And on the future research level, I think this throws up a couple of questions for us on the next slide. So we would invite primary researchers actually to ask that question within their studies. What matter actually comes to matter in studying a complex healthcare topic in what we have come to see as a multi-agentic world, and how that reconfigures our ideas about relevant assemblages of things, people, experiences, ideas. What you see next on the slide is a couple of questions we had. You know, how do you measure the quality of such outcome? What if I can't draw? What are the alternatives to engage with this type of physical storytelling, if you like, and how can we move that into a broader research community? So this is probably a good sum up, and where I want to show a slide of people we would still need to acknowledge for their input, and then perhaps open up for questions. Thank you for being with us. If you don't have any pertinent questions, it would also always be interesting for us to know or to learn what the one thing or thought is you take away from this seminar that might change the way you look at your own evidence, your own phenomenon, once you will be back at your own individual chair, if you like. So curious to hear what you've learned from this.
Hi, Karen and Lynn. Thank you both so very much for that really insightful, really interesting presentation, and great to see the fruits of your labor and all your hard work coming to fruition. So if anyone has any questions, please do submit them in the Q&A box below.